Hi, everyone. We're just waiting for our room to fill up. We see participant numbers going up, so welcome. Good afternoon. My name is Stephanie Ventura, and I'm the Director of Education with the Ontario Association of Residence Councils, or OARC. At OARC, our mission is to empower long-term care residents to understand their rights, share their lived experience, and inspire a better tomorrow. We do this by working together with our partners to educate the long-term care community and beyond, to build a collective voice and to create positive culture change. Welcome to OARC's Webinar Wednesday, where we explore topics of importance to residents. Today, we're pleased to welcome and partner with the Ontario Patient Ombudsman, Craig Thompson, who will be speaking to you about the role of the Patient Ombudsman's Office and sharing some insights into the types of complaints and calls that they receive. Craig Thompson was appointed Patient Ombudsman in March 2021, having first served as the Executive Director since 2017. Craig has more than 30 years of leadership experience working for public and private organizations in healthcare, design sciences, and communications. Craig is passionate about improving the quality, safety, and experience of healthcare in Ontario and is actively involved in the Canadian Ombuds community, promoting the importance of ombuds in Ontario's healthcare system. You'll join me in a land acknowledgement. On the next slide, please. Thank you. Together, let us now pause as we acknowledge the Indigenous peoples of all the lands that we are on today, from wherever we are virtually participating in today's meeting. Let us take a moment to acknowledge the importance of the land we each call home. We do this to affirm our commitment and responsibility to improving relationships between nations and to improving our own understanding of local Indigenous peoples and their cultures. We acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nations people who call this nation home. Let us now join in a moment of reflection to acknowledge the harms and mistakes of the past and consider how each of us in our own way can move forward in a spirit of reconciliation and collaboration. Thank you. On the next slide, here's our housekeeping slide. This webinar is being recorded and a copy will be made available on our website along with the accompanying slides. You'll notice that the chat feature is disabled. We do welcome you to share your questions and comments in the question and answer box, and we've protected time at the end of the presentation for questions. Anne Donaldson, an OARC board member and resident advisor, will join me in posing your questions, both those received during this presentation and those submitted in advance through the registration process. Thanks in advance, Anne. And with that, I'd love to hand it over to Craig Thompson, Ontario's Patient Ombudsman. Welcome and thank you.
Thank you, Stephanie. My name is Craig Thompson. I'm the Patient Ombudsman for the province of Ontario, and I'm joining you from Toronto, which is in the territorial lands of the Mississaugas of the Credit First Nation. It's really a pleasure and a thrill for me to be able to speak with you today. I was talking earlier before we started with Anne and Stephanie and Melissa just about how important it is to be able to connect with residents and hear from you about the experiences you're having in long-term care, but also to talk about some of the what we're hearing in the work that we do as an ombudsman, and reflect back to you what we're hearing, but then also talk a little bit about where we can help, because we see ourselves as partners in care, and we are fundamentally of the opinion that the better experience people have in healthcare, the better the healthcare. And ultimately, that is the goal of our office. I've turned this presentation a little bit on its head from what I would typically talk about. Normally, I would talk about myself and my organization. But I think really I'd rather talk about the stories and the information that we're hearing from residents and family members of in home care or in long-term care. And that really comes from the information that we collect as part of our work, collecting complaints and reporting it through annual reports and other kinds of reports. So I'm going to talk a little bit about the data that we've been collecting over the last year and just reflect a little bit on that. And hopefully that will give you a sense of what it is that we're hearing and also what it is that we can do to assist and what we are helping organizations to do to respond to the concerns that you might have with the care or experience of care that you're having in your homes. So first of all, as you know or might not know, Ombudsman, we are in the business of complaints. That's what we do. We receive complaints from all areas where public monies are spent. Any public service in Ontario, or at least most, and across Canada and around the world, will typically have an ombudsman office in place that allows those people that get those services that are public funded to have a way to talk about things that aren't going well or to complain. And we want to making that complaint as easy as possible. So our office is very much trying to make sure we cover all the bases when it comes to how you can complain. So most of our complaints come in through the phone, and as I was saying, mentioning to Anne earlier, we like to pick up the phone. We want to be able to answer that phone with a real person and a warm voice who can help people that are having challenges within the healthcare system. So we have a local number here in Toronto. We also have a toll-free number. Also, if you're technically inclined, we offer lots of information about our office, more access to data through our website. And so you can go online and visit us on our website. We also take the tried and true way of getting mail, taking a fax, and even in-person appointments. Post-COVID, we don't see as many in-person appointments than we did previous to COVID, but it is certainly something that we're happy to arrange because we know for some families and residents, that's really the way that they want to be able to interact with us. We also make it as easy as possible to communicate in any way you feel most comfortable. So whether that's speaking in a language that you're more comfortable in, whether it's receiving materials in a language that you're more comfortable in, we will do what we can to make sure that we can provide that information to you. So that includes, we have English and French speaking staff. We allow simultaneous translation in all languages. There's not a language that we have not been able to provide that in. We already in advance have translated a lot of our resources into 22 of the most popular languages in Ontario, including 6 Indigenous languages. So all to say, we want to make it as easy as possible to complain because the more complaints, the better. That for me is really a sign of success is if our complaints continue to go up year over year. And so that's what I'll talk about next, which really is just how many complaints do we get? And are they increasing? And yes, they are increasing, and that's a good thing. And they have grown quite considerably since we opened our doors in 2016. So when we opened our doors in 2016, we were doing about 1,350 complaints a year. We're now doing over 5,000 complaints. Our team has grown with that as well. We used to be about an office of about 15 people. We're now an office of 28 people. So we are growing with the complaints. And as I said, to me and our office, the more complaints, the better, because that means that we have a healthy feedback mechanism, if I can call it that, where people who are getting services, whether it's in long-term care, home care, or other areas of the healthcare system, feel that they have an additional venue or support that they can turn to if something's not going well for them. So the more complaints, the better, and that seems to be bearing its being the experience that we are having in our office. So who do we get complaints from? So we get complaints primarily from residents and patients. So residents of long-term care and patients of hospitals. or patients who are receiving care in their home through home care. That is really the number one. More than 50% of our complaints come from the actual users of the service. And so we are talking with residents and patients every day about the experience that they're having with the healthcare system. And then we'll also, next in line, we would be talking to those patient and residents' family members. Could be a daughter, a son. It could be another substitute decision maker, and taking the information from them about the experience that their loved one is having. And then partner, spouse, a parent or a guardian, other family members who really just have concerns, may not be a substitute decision maker, but have observed something that is concerning to them. We also receive complaints from the teams, the healthcare team, so care and service providers, who have either observed something that is of concern, or they're looking for some advice and guidance as to how to deal with a complaint that they've got, where maybe they're just not getting the results that they're hoping when dealing with the resident, or they've maybe run out of ideas, and we might be a way to get some new ideas. So we get this is the types of folks that are contacting us. But as I said off the top, it's predominantly patients and residents who are contacting our office, and that's predominantly by telephone, which is where we get our complaints. And we get complaints because we are the Ontario Ombudsman from across the province. Predominantly, we get complaints from the Toronto region, and when we look at breaking that down by population, so per 100,000 people in these regions, most of our complaints come from Toronto, and that really speaks to the fact that there's just that many more healthcare organizations in Toronto, more hospitals, more teaching hospitals, more long-term care homes. There's more home care, there's more people here. So Toronto is really the number one area for where complaints come from. But that is followed, and it may not be intuitively, by the north. So we're talking about the far north and the near north. And that's where is a second largest source of complaints when we correct for population. And so maybe not something that you would expect, but recognizing that in the north, access to healthcare is just that much more challenging. They have larger issues around distance in terms of travel. Weather creates problems. Just having access to the clinical people and equipment that's necessary to do the diagnostics and provide the care is a little more challenging in the north. So that is our second in terms of regions of where the complaints come from. And then it's followed pretty much in rapid succession with the west, east, and central parts of Ontario. But we have gotten complaints from every region in Ontario and pretty much every organization which is under our jurisdiction, and it's thousands of organizations that we have jurisdiction over. So hopefully the word is getting out about our office, because again, we would like everyone, it's not that we would like everyone to have a complaint, but if you do have a complaint or concern, we would like you to know that we are an office that you can call. And if we can't help you, we'll try to do our best to find someone that could answer your questions for you. So in terms of the healthcare sectors that my office has oversight over, or jurisdiction is the word that we use in the ombuds world, we have jurisdiction over four main areas of the healthcare system. It's not the entire healthcare system, but it's the big portion of it. So public hospitals, and that's all public hospitals within the province are under the jurisdiction of this office. All long-term care homes, home and community care that's delivered through the Home and Community Care Supports Services Sector organization, as well as a new jurisdiction that we received in September of 2021, I think, which was community surgical and diagnostic centers. So these are all of the diagnostic centers, and there's over 1,000 of them, where you get x-rays, ultrasounds, certain kinds of surgical procedures, cataract surgeries. Those are also within the jurisdiction of our office. And then always we have areas of the healthcare system that we call non-jurisdictional, or outside of our oversight, that we still get complaints about, and predominantly that would be primary care. So the primary care sector, which is all of our GPs, and community health centers, walk-in clinics, make up a good portion of those complaints that we receive that are outside of our jurisdiction. So we can't really deal with them in the same way that we can the ones that are within our jurisdiction, but we certainly try to give advice and guidance. And when it comes to where do complaints come from, public hospitals is really the biggest area for complaints. And that's not because public hospitals are doing any worse a job of delivering healthcare. They're just that much larger. There is just that many more, healthcare interactions in the public hospital system than there are in long-term care homes or home and community care combined. There's just a lot of care being provided in the public hospital system, and so that's where we see complaints. But then it's followed right on the heels by long-term care homes and home and community care. And the percentages that we had in 23, 24 were over 50% were public hospitals, and then long-term care homes were 8%, and home and community care were 6%. Those proportions really have not changed much since we opened our doors in 2016. And so there's a couple reasons. I've mentioned one, the fact that hospitals just do that much more delivery of healthcare. That's why they're always number one. But also the long-term care homes, and I'll speak to that specifically, those are different settings. Those are very unique settings in that these are people, these are your homes where healthcare is being provided. The care is being provided in your homes, the relationships you're having with your care teams, and the folks that you interact with every day are very intimate, personal relationships where there is a reluctance, I think, to complain about individuals that you have such an intimate relationship with. And so we see that as being one of the reasons why we might not see as many complaints from long-term care homes or people in home and community care. We also know that they have a very, very comprehensive and robust complaints sort of system behind them. There's a lot more people available to be able to provide support and to be able to try to address a concern because of that strong interpersonal relationship that they have with their residents. But at the same time, I think people are reluctant to complain. But in long-term care homes, and maybe one of the things that might come out of this session today is for you to feel much more comfortable with the fact that if you did call our office because you're not sure that your concern was being taken seriously, or you're really not getting things aren't changing the way that you would expect them to change once you've raised a concern, then you can feel comfortable to call our office. We're happy to take the information confidentially. If you choose just to speak to us about the concern and you're not looking to make it a formal complaint, that's fine as well. We'll provide information as best we can. If you do want to make a formal complaint with our office, we are very respectful of the relationship that you have with the home, and we are really always in the business of wanting to reinforce relationships and not pull them apart. So I always say that the work of an ombuds is unique in the fact that we are in the relationship business. We really are trying to strengthen relationships, help people to help others, to learn from the complaints that they receive. So the other sectors that we have jurisdiction over, which is community surgical diagnostic centers, we don't get a lot of complaints from that sector as yet because it's quite a new sector to us. We're not as familiar with them and they're not as familiar with us. And I don't think patients who make use of those centers know that we are even part of the complaints process, but that over time I think will change. So that's generally where we get what sectors are providing us with the work of trying to get to a resolution of complaints. And always people ask, okay, so what are people complaining about? And so that's always the number one question we get. It's an important question. It's one of the key reasons why we take a very, I would say, analytical approach to how we look at complaints, because we want to be able to take that information and make use of it. It's, one complaint it's important that we resolve that complaint as best we can, but we want to make sure we make use of that and bring all the complaints together and see if they're telling us a story about a theme or an issue that is not only affecting one home, but affecting multiple homes. And that's really where we want to be able to make a difference, to make sure that we are listening to what the complainant is telling us, to see if that is this just a one-off issue, or is this something that more homes and individuals are experiencing, and so that we have a role to play in trying to fix that for more people. So in terms of the top five, I've put on this slide, it's maybe not the easiest thing to read, but the top five for the 4 sectors that we have jurisdiction. I'll just zoom in on the long-term care homes area, but recognizing that each of the sectors, they have their differences, but they also have their commonalities. You'll see that the quality of care appears in 3 sectors. It's the number 1 complaint from long-term care home residents and their families, which makes sense. These are healthcare. Your home is where you're getting care, and quality is everything. Quality of care speaks to the quality of your life, the quality of whether you're thriving and doing the best that you can in your home. And so quality of care is making up in 23 and 24 years about 37% of the complaints that we got from long-term care homes. And that's followed by communication. And you'll notice communication also occurs in other sectors. And communication is really fundamental. If I like to think, and the data bears this out, communications underlies most problems. If there's a breakdown in communications, you're going to have an issue. And so no quality healthcare cannot be delivered if you're not a good communicator. And when communications breaks down, that leads to problems. So we see communications as being fundamental to what can lead to a complaint. So a lot of our suggestions and recommendations about what might be a resolution to a complaint involve communications. And then it's followed by, at least in long-term care, abuse and assault. And this is, unfortunately, again, it's 5.5% of the complaints, so it's not a large number, but it's still there in our top 5 complaints. And this could be coming from a resident, a staff member, a member, another family member, where there's an abuse or an assault occurs in a long-term care home. So this is very concerning to us. These are always highly prioritized types of complaints that we receive, and we move very quickly to understand what is going on in those circumstances. Number 4 complaint in long-term care is around what we call discharge, transfers, and transitions. And this is, again, common to all sectors in healthcare. Anytime you're moving from one place to another in terms of getting your care in a hospital and moving to long-term care, or being in the community, being in your own home and moving to hospital, that always gives rise to some situations. Everyone's situation is unique, and those are complicated changes that have to be managed in a very sensitive way. And so we see complaints, and have always seen complaints in those areas where someone's being discharged from hospital, either back into the community, back to their home, or into long-term care, whether being transferred from a hospital to a rehabilitation center, or a hospital to long-term care, or there's transitions where people have gone from a hospital to rehabilitation, to home care, to back into their home. Anytime there's a change and there's people are handing over from one care team to another, leads to issues. And then finally, again, a concerning one is the personal security and safety in long-term care. And this speaks specifically to the personal safety of the resident, particularly from falls and fall prevention systems, if fall prevention systems aren't doing their job, if the environment is not safe, and that can be broadly interpreted, where people just don't feel comfortable in their home for a lot of different reasons. So that's what personal security and safety fall under. So those are the 5 top complaints for when we are reporting for years of 23, 24. It does shift year over year. We're very interested to know why these shifts occur, particularly when we see a complaint like number 3, abuse and assault. Why is that happening? Why is that occurring? What are the circumstances? that might be leading to that situation, and what can we do as an ombuds office to make sure that the government understands and the homes understand what it is precipitating that, and also the personal security and safety. These are in our minds preventable. These should be never events. They should never happen. And so when they do, we should take notice. And even though it's a small percentage of our complaints, they're very important to us. Well, we certainly sit up and take great notice when we get complaints like that, because we know if someone's experiencing that, somebody else is as well. And that's really the fundamental piece of the work of an ombuds. While you may think, 5,000 complaints in a healthcare system as big as Ontario's, it's not that many, but we know that behind every complaint, there are dozens of people who are having a similar experience, and we need to, and that one complainant is their voice, and we honor that, and we want to do the best that we can to support that. So this one slide, and I've gone through a little bit about what those complaints mean in terms of quality of care. Just really quickly, when we say quality of care is impacted, that could be poor pain management. Someone's just not having their pain managed or symptoms managed appropriately. In home care, certainly skin care and wound management is really important. And so that falls within that quality of care umbrella. But it's also quite, in terms of us being able to report that, we sort of roll it up into these sort of broader categories so we can have a better way of communicating it. Communication, I've talked to you, excuse me, I've talked a little bit about what communications looks like when it's not working. It can be as simple as people not sharing information with the resident or their families. Sometimes that can be just the fact that someone didn't say something, someone didn't tell me or write it down. It can certainly be cultural or language barriers. We see that a lot. Or just not an opportunity to ask a question or being given time. Something that we talked about, Stephanie, before we came on today, is just having the time to be able to reflect on what's being said to you so you can make the best decision that's in your best interest. And sometimes this just takes, some time. Abuse and assault, I've talked about a little bit, but that can be verbal abuse. It can be physical. It can be sexual or financial abuse. We've seen complaints about all of that. Again, it's very disconcerting when that happens, and so we take it very seriously, and we move very quickly to understand what is going on there. I've talked about discharge, transfers, and transition. Planning is, planning. You've got to plan for these discharges, these transfers, and when the planning is not where it needs to be, you get problems. And so that's one of the things that we are constantly reinforcing with homes and those organizations in our jurisdiction, that you've got to do the planning. And then personal security and safety, I talked about falls and the never events, accidental injuries. There really is not. Accidents do happen, but they shouldn't happen. And certainly there's a requirement to always provide a safe environment for residents. So when you come to us with a complaint, what do we do? So first of all, we pick up the phone. We take your call. We get most of our complaints from over the phone. That's what everyone seems to be most comfortable with, and that's always been the case. And we will spend a lot of time, or as much time as required, to make sure that we understand what the complaint is about and exactly what is the story behind the complaint, and recognizing that sometimes these stories, it's not just one thing, it's been a few things that have gone wrong, and it may have happened over a long period of time. There is no statute of limitations in our office, so we can get complaints, and we had from things that have occurred 10 years ago. You can recognize, though, that's a challenge for us to try to do much to really try to resolve, because people have moved on, memories have faded. But there is nothing that stops someone from complaining about something that occurred quite a few years ago, but that is not the norm. But we do spend the time necessary to listen to what the complaint is. And that also means we're not only listening to the resident or the family member, but we're also going to be calling the home. and trying to understand their perspective, because an ombudsman is not an advocate for a patient, and we're not an advocate for the healthcare system. We are unbiased and impartial. We walk right down the middle as best we can to hear both sides of a story, and then try to understand where's the truth in that, and where's the facts, and then we try to come to a resolution that is fair and reasonable. And so, while we are called the patient ombudsman because we know that the complaints come from patients and residents, we are not advocates in the clearest, in the truest sense of the term, but we do advocate for fairness. We want to make sure that people are treated fairly by organizations that are publicly funded. And so we spend the time to listen to both parties to understand exactly what's going on. We then do a lot of work around researching options, looking for solutions, trying to find common ground to where there might be a resolution, understand what people feel is important that gets resolved. We may request more information from both the resident or the complainant and the organization, and that could be health records, it can be policies, it can be video tapes from closed circuit television. We are in the evidence business. We are evidence based, so we would collect only as much evidence as we need, recognizing that it's always confidential. We are dealing with people's personal health information and personal information. We only ask what's needed, and we do not disclose unless we have the consent of the resident or their substitute decision maker. So if there's something that we need to ask from a home in terms of information, we will make sure that we have the consent of the resident first, so that you understand why we're asking for it and what it is we're asking for. That's really important in the work of our office. But then we will also do things like participate in meetings. Sometimes that can be a way to unblock, and get to a resolution. If we're just at the table to be able to provide some assistance, we will make suggestions. Again, we're not in the business of telling organizations what to do. We are not clinical people, typically. We're not experts, but we certainly are curious folks, and we know how to ask questions, and we understand a little bit from what we've heard what might work. And so we're very much willing to offer up some advice, but we won't be telling anyone what to do. And we actually cannot compel an organization to do what we say. That is not the way an ombudsman works. We are in the business of moral suasion. We persuade by making good arguments as to why we think this is going to work. But in those cases where a home or an organization in our jurisdiction thinks, no, they might not think that we have the right idea, we have the ability, and it's backed by legislation, to continue to follow up with that home until we're satisfied that they have taken seriously what we said. They can approach the solution any way they want, as long as they've taken it seriously as to what we said, and they're working in goodwill to address the concern that was raised by the complainant. And in the odd time, we also do what's called a mandatory report. It's unique to long-term care. If we hear of a situation from, it could be a resident, it could be a family member, it could be a staff person, it could be a member of the public who says, I'm seeing something in a long-term care home, I'm concerned about it, and we as well feel like there's somebody's health and safety is in jeopardy, we will make a mandatory report, which is a direct call, our communication with the Ministry of Health and Inspections Branch, to let them know that there's something that we're very concerned with, and that is a highest priority for us. And then once we've had that conversation with an organization, what do they do? And typically what we want to see is them to acknowledge that there's an issue. And so they acknowledging the complaint. We want to be able to know that an organization has heard us and understands what it is that we're concerned about. So they have to acknowledge it not only to the complainant, but acknowledge it to us, so that we see heads are nodding and they're going, yes, we see that there's an issue here. We're open to having a discussion with you. Sometimes that also means that maybe it's a service that they weren't providing to a resident or a complainant. They decide that service is it's been a misapplication of a policy, or they didn't understand all the factors, or it's something got caught up in red tape. They provide that service. That does happen. They often offer an apology. People in healthcare don't come to this work because they want to create problems or not deliver good care. It's just not the nature of the work. And that's, in 99.9% of the case, people come to healthcare because they want to help. And so an apology is a recognition that something didn't go as well as they would have wanted. And so it's offered many, many times. Sometimes it also, an organization will commit to providing training for staff, more education. Maybe a policy just wasn't quite understood as well as it could have been, and it was applied either inappropriately or inconsistently. Sometimes there isn't a policy, and so a policy needs to be written so that everybody is on the same page and they understand this is how this works and this is what we do for everybody. We're not making special cases for someone. We're not misapplying the rules. We want to be fair to everybody. And so we will make those suggestions for certain policy gaps. And that happens quite a bit of times. Sometimes, and this is even in a universally funded healthcare system like Ontario, people still are charged fees. And sometimes those fees are inappropriately applied or unfairly applied. It happens more predominantly in the hospital sector, but it does happen in long-term care. And we do talk about if we feel a fee has been inappropriately applied, having that fee waived or adjusted in some fashion. Because if it's not fairly applied, then it's not fair, and it would not make sense for a resident or a patient to have to pay a fee for something that they didn't actually, it wasn't appropriate for them to be applied to. So that's sort of some of what we can achieve through our work. The caveat I have there is every complaint is as unique as the individual behind that complaint, and every resolution is the same thing. Sometimes it's not so important. Some that we think is important for someone to get resolved is not important to the complainant, and so we won't. It's not our complaint. It's not our experience. We will try to work with the individual to make sure that we understand what's important and try to make sure that we focus on that. And try to get to resolution on that, because that's really what we're being asked to do. So that's the first part of what I was going to talk about, which is the data. And I hope I haven't been speaking too quickly, and I hope this has been helpful for you to get a sense of the kind of work that we do as an ombuds. I'm now going to spend just a few minutes talking about the office of the ombudsman, so you get a better understanding of how we fit in the healthcare system in Ontario, and what we can and maybe what we can't do, but where we can try to help. So as I've spoken about ombudsing in general. So I'm an ombudsman. I like to refer to myself as an ombuds. I have a team of very dedicated, committed folks that work with me to ensure that people are treated fairly by public organizations. And because we are a healthcare ombuds, those public bodies are hospitals, long-term care homes, and home and community care, and those diagnostic centers. As I said, we promote fairness and accountability in the administration of public administration, and we're independent. We are not an extension. While we're funded by government, we operate entirely independent of government. We do not take direction from the government. We decide, my office decides, I decide what it is that we will pursue and what we won't pursue. And we provide that impartial oversight. So that's very important to us, that independence piece, that impartiality piece, and the confidentiality. We also live within a piece of legislation called the Excellent Care for All Act that gives me my jurisdiction. So we don't play outside our sandbox, but it doesn't mean we know a lot about areas of the healthcare system outside of our sandbox. As I mentioned, we are a health ombuds, which means we are very specialized. We are one of the very few health ombuds in the world. There is maybe 2 or 3 in Canada. The only other true health ombuds that's all they deal with is an Indigenous health ombuds out west. Other ombuds within Canada have elements of the healthcare system in addition to other areas of government, but we are the only in Canada dedicated healthcare ombuds. So this is our business, and this is what we're focused on. I feel that's important because Ontario's healthcare system is large and multifaceted, which is another way of saying highly complex. It's not easy to navigate. even when you're well. It's really that much more difficult to navigate when you're not well. And the complaints process is as complex. And so sometimes just you can be at really loose ends as to knowing where to complain, what can I complain about, who should I be talking to. That's the work that we do. And if we're not if you've come to us and you're just seeking information, that's fine too. We will give you the information so you can advocate for yourself. And if in the end you still need our services because you're not getting the satisfactory resolution, then you can come to our office. But we are a healthcare ombuds, so we know healthcare. As I said, we are a creature of a statute called the Excellent Care for All Act, which was passed in 2010, which led to the creation of this office in 2016 with Christine Elliott as our first patient ombudsman. The vision for this office is pretty simple. It's a healthcare system where everyone is treated fairly. That's all we ask. I know it's a big ask, but that thing is pretty simple. We just want a healthcare system that everybody in Ontario feels that they've been treated fairly. And we do that by resolving complaints. We share information, and where we can, we make recommendations to organizations and the government to improve the healthcare experience for everybody. I've talked about our jurisdiction. This is a little bit more detail about the public hospitals. There's 140 across the province. It's a lot of hospitals that we have jurisdiction over. The 630 or so long-term care homes, the 14 home and community care supports service organizations that provide home care across the province, and the 900, almost 1,000 community and surgical diagnostic centers in the province. So it's a big area of healthcare. As I said, it's not the entire healthcare system. And I mentioned primary care. We also do not have jurisdiction over public health units, community health centers, and we also are not regulators of regulated healthcare professionals. So if the complaint is solely about the clinical decision making or the professional conduct of an individual doctor, nurse, physiotherapist, that is not our jurisdiction. That is the jurisdiction of the regulatory colleges. We're happy to give you the information to those colleges. That's where you go for a complaint about an individual in those situations. And typically, as what is referred to for ombuds, and this is all ombuds, we're an office of last resort. What that means is we really want you to have given the organization a fair chance at resolving your complaint. And that really makes sense on a lot of levels because that's where you're probably going to get the quickest response, probably the best response, because everyone at that point is vested in getting and making sure that this gets resolved quickly and to your satisfaction. So raising it with the home first is the first best step. It's really once you've hit a roadblock and you're not getting the resolution that you're satisfied with, or you feel that they're not taking it seriously and it continues to happen, that's when you would typically come to our office. But we recognize that not everyone's in the same circumstance where they may feel comfortable or safe making a complaint to one of their care providers, and they would feel more comfortable coming to an organization like ours, which is impartial, independent, where confidentiality is implicit, then that's actually an option as well. So whatever people feel comfortable with, we're happy to accommodate that. So a little bit of the do's and don'ts of the office very quickly. As I said, we rely on the facts. We try to collect information as best we can to understand exactly what the situation is. We're not looking for fault, but we're looking for the facts. We don't want to lay blame, but we do want to understand what happened. We always ask for consent, as I mentioned, if we're going to be asking for or sharing personal health information. If we're not the office that can help, we'll give you the information for the organization that might be able to help. We won't be able to connect you directly to them, but we will certainly give you the information to allow you to do that. And we encourage you to patients, residents, caregivers, members of the public who are having issues with the healthcare system in Ontario, call our office if you have questions. That's really the best advice I can give. So what we don't do, we don't investigate or accept every complaint we receive. Sometimes people are looking for something that we just cannot deliver because it's not within our ability to deliver, or it's not appropriate. Best example of that is someone is calling us and saying, I want someone to get fired. I want them out of the home. That's not something we will pursue. We are not in the naming, blaming, shaming business. We are in the business of trying to get to a resolution. So if that's the starting point, that will not be a complaint that we would proceed with. We do not submit complaints on behalf of people. We cannot be someone's proxy or an advocate per se for a resident. And so we won't take your complaint for you on your behalf. It has to come from the resident or the substitute decision maker. I've mentioned that we can't force or compel through law organizations to act or adopt our recommendations, but we certainly have the ability to be very persuasive because we do work in the world of facts and we do have a lot of experience. We don't give legal advice, but we will tell you if we think you need legal advice. Sometimes people are looking that they want to start maybe a process of suing someone. That's not our area, but we will say maybe that's something that you need some legal advice. And we don't take sides. We don't advocate for one party over the other. We try to remain as impartial and as unbiased as we can. And that's really the last of my slides. I hope I didn't talk too quickly or cover too much territory. If you have questions, I'm happy to answer them. I'll leave you with some of our phone numbers and our website. That's the best way to get a hold of us. And with that, I will give it back to Stephanie and Anne if there's questions.
Thank you so much, Craig. This was super impressive. I'm echoing the comments from our friends at Kipling Acres, their residents council, who are tuning into our presentation this afternoon. And they'd like you to know that this was very detailed and impressive. So thank you for those comments, Kipling Acres, and thank you for joining. We do have some questions that have come in through the registration, and Anne has those queued up. So I'll hand it over to you, Anne, for our first question.
Okay. What accessibility supports are available to residents who wish to engage the Ombudsman?
So we provide as many different ways of being accessible as we can. So the most basic ones being in terms of language. If someone is English is not their first language or French is not their first language, happy to have the conversation in the language that is most comfortable. There's various ways that we do that through simultaneous translation. Sometimes we get lucky and someone on my team speaks not only English and French, but another language. We're happy to accommodate that way. So that's the first piece. We also know that it's sometimes hard to write a complaint. And that's one of the that when we first opened our office, that was a requirement that we received our complaint in writing. And we know sometimes that's just not comfortable. That's just not something someone feels that they can do appropriately. And we will actually listen to the complaint, document the complaint as best we can, and then give it back to them and say, did we capture the nature of the complaint? And then work in that way with an individual. We do have sometimes a complainant will come to us who is comfortable having a family member with them on the call, or someone who's a support person, for a lot of different reasons. And we're quite happy to be to accommodate that, because we feel the more comfortable they are, the better information is that we'll get from an individual. I mentioned that we do offer the ability for people to come to the office for an in-person. It doesn't happen very often. We've all, I mean, one of the, I don't know if it's a benefit, but one of the things that the pandemic has taught us is that we can do quite well to be able to use technology to get to places we could never get to before. So there's that option. We also recognize that in many cases, people are not at their best when they come to us with a complaint. And that could be for a lot of reasons. A, they could be unwell. B, they could have experienced something in their life that has led to a trauma, and the trauma informs how they remember a story, how they want to tell a story, and certain elements of a story that they feel very vulnerable to speaking about. All of my team, myself included, are trained and educated in trying to get to the elements of a story without re-traumatizing somebody. So if that means that we need to have multiple phone calls at certain times of day, we will do that. If it means that we will have to have long breaks in between receiving a complaint, we will do that. So whatever we need to do to get the complaint, we will do to the best of our abilities. And I think we there's always something new where somebody's has a barrier that we didn't think about, and hopefully people feel comfortable to tell us about it, and then we'll do our best to try to accommodate it.
Good. Thank you. What's the role of the long-term care home during an investigation by the Ombudsman?
So there's two parts of our work. So the first, most of our work is done on what we call the early resolution process, which is that sort of informal communication between a member of my team and the home care and the home. And so we'll be talking over the phone or through email with whoever we need to speak to, whether that's the care coordinator, whether it's the director of care, whether it's the administrator, a nurse, is whoever we need to speak to, we'll be communicating. And it's a very much more of an informal point. And that's predominantly where the work gets done. And so a home is cooperating in that way, that the role is for them to cooperate. When my office calls, while I mentioned that we can't compel people to do what we ask, they are compelled to interact with us. There is not really optional. When the Patient Ombudsman's office calls, a home is required by legislation to respond to us in a timely way. If we find that we are not getting the response that we're looking for with a home, we will move to a more formal process called an investigation, a true investigation. It's a very formal process. It is with it, we get certain actual legal powers to subpoena. We can compel an organization to provide data, records, video. We can compel an organization to give witnesses, to be a witness. So at that point, we are into a much more formal process, and in that circumstance, there is no option. A home or a hospital or whoever's in our jurisdiction must cooperate in a timely way with this office.
Does the Ombudsman inform the Ministry of Long-Term Care policies and priorities?
Yes, we do, but not in a way where we are asked. There's no direct connection to the Ministry of Health or the Ministry of Long-Term Care. Beyond that, our office reports issues that we are concerned about publicly. And so when we report publicly about issues within long-term care, those reports go to broadly across the province and to the ministries of health and ministries of long-term care. We also have connections through my office to a liaison group within the Ministry of Health and Long-Term Care, where if there's some issue that we're really seized with, that we feel is really troubling, then we can open a channel to communicate with them. That would inform policy, but it's not a direct connection. Having said that, we do in the past we have, and this is more in particular to the well, I guess it's related to long-term care, but also the hospital sector. There is a Bill 7 that created a new rule that they didn't need consent from a patient in order to start the process of planning for long-term care placement. Before Bill 7 came into effect, that piece of legislation you were required to give consent of the patient before you could start that process. Bill 7 changed that, and in advance of Bill 7 getting royal assent and becoming a law, we actually proactively communicated out to the healthcare, to the home care, long-term care sector, where we anticipated there could be some problems, some issues with that. Because when someone loses the power of or the agency of consent, that is one of the stopgaps that allows us to make decisions in our best interests, our own personal best interests. We saw a problem with that, and so we were proactive in that. So in that sense, we responded to policy, but we didn't inform it. We look at the inadvertent outcomes of policy, right? If a poor policy leads to poor outcomes, we're in the poor outcomes business. So hopefully, if you can learn from what we're observing, you can write better policy.
But you're not required by law or any other reason to tell the ministry what has happened.
Oh, we're required in terms of our mandate to be public.
Okay.
And so we are required. I am required to report publicly. I'm accountable to the government because they fund us, and I'm accountable to the sector because we have oversight of them. But we are required to report and communicate. It's often in our world called telling truth to power. An ombudsman is fundamentally doing that work.
Okay. And finally, my final question is, does the ombudsman help provide direction or recommendations for investigations by the Auditor General?
Not per se, not directly. We certainly, I think the data that we share, because when I say when we share publicly, we share with like organizations like the Auditor General, also the Privacy Commissioner, the regulatory colleges, they all get our information. We are informing their work, their investigations. If someone requested data from us, again, it has to be confidential, and we would never share personal health information with anybody. We would provide the data that we can publicly disclose, which is de-identified. We would be happy to share that. But yeah, there's no direct connection.
Okay. Stephanie? Stephanie? She's frozen.
I saw that.
I'm back up, Stephanie. Stephanie's internet. I know everyone's been affected by internet outages today. And so Stephanie just sent me an emergency text message that her power has gone out. So apologies.
Do you want to ask the questions in the question and answer, Melissa?
I'm just trying to make sure that we haven't covered some of these. Okay, apologize. Okay, so there's a question, and I'm not sure if this is going to be something that can be answered on the spot here. How many complaints have come in comparison to how many have been resolved? And that's coming from the council at Lake Ridge Gardens.
So if all complaints are resolved, and the caveat to that is it's not always resolved to the satisfaction of the complainant or the organization. And that is the work of an ombuds. No one's ever entirely satisfied with us or happy with us, but that's that independence piece. That's that impartial, unbiased, independent piece. We understand the story from both sides, and we try to be as unbiased as possible, but ultimately every complaint is resolved. It's not everyone's happy with us. We'd like to say most are, but not everybody is.
Thank you very much. I've got another some great feedback from the residents and team at Seven Oaks, commending you on an informative session. And they had a question about, and I think this is more like the triaging, like once a complaint is received, how long does it take for the person who submitted the complaint to hear something? And I know it might depend on the level of risk, and you have an internal process for kind of.
Absolutely. So every complaint will be acknowledged within 2 days. So we will tell you within 2 days that we've got the complaint, but every complaint is looked at as soon as we get it, the day of, because we know that sometimes people are coming to us with a complaint that is very serious and someone's life and limb is in jeopardy. someone's in a unsafe situation, someone's not getting care, and so we look at them every day, and that's part of our triage process. We then look at each complaint on its merits. Some complaints obviously have a priority to them in terms of what's the situation. Someone needs something resolved really quickly. Others can be quite historical. So time is not such an issue, but we want to be timely. We are really working hard to make sure we don't waste people's time, that we are as timely as we can. Most of our complaints get resolved within 3 to 6 months. That might seem like a long time for people when you're really concerned about something. But again, based on the priorities and what the circumstances are, we work as quickly as we can. One thing we ask from complainants, if their circumstances change, let us know so we can try to respond as best as we can.
And if I just add to that, if it is going to be well, you don't know in advance if it's going to be a long complaint, do you correspond with them? You say 2 days, no, definitely, we're on it. But if it's going to be a long complaint, or you've gone for 2 or 3 weeks, do you send another follow-up and say, yes, we're still on it, we're still working for you type thing?
Absolutely, and we can always do a better job of that. But it's really that's just good service, is that if, sometimes it takes time for an organization to respond to us, recognizing sometimes we're asking for a lot of information. And we like to keep everybody in the loop. So yes, and it's good service for us to be able to keep everyone informed. If you don't hear from us and it's been a while, please call.
Yeah.
And don't hesitate, just call.
Great, thank you.
Well, thank you so
Wonderful.
much. Thank you,
Stephanie's
Melissa.
back right on cue.
Thank you so much for jumping in, Melissa, and thank you to everyone who tuned in today for your thoughtful questions. And thank you, Craig, for this beautiful presentation. Just listening to you talk, I see a lot of alignment between our two organizations, especially when you said that you get a lot of calls and you like to focus on the relationship and what's being said, but also that some of your calls are not entirely always related to what you do, but that your team is curious and you like to connect people to information that might be of use to them and to share ideas. We do that a lot in our own work as well. I know our name is Ontario Association of Residents Councils, but we do so much more, and we hear from residents across the province with all kinds of questions. So I really appreciate and can see alignment with how we do our work, and the focus on relationships, and you're in the relationship business. So nice to hear this. I have to say, before listening and watching your presentation, I wasn't sure if I would have picked up the phone and called the Ombudsman's office as comfortably or as readily, but after listening to you and even our conversation before this, that our audience wouldn't have heard, just pick up the phone and call. If the office can't help you, then they will certainly direct you to someone who might be able to help you. And as Anne said, the worst they can say is no, but it sounds like after listening to Craig that it would be no but.
Yeah.
Or no and.
No and, yes. So thanks so much, everyone. I hope you'll take a few moments to fill out the evaluation that's going to pop up on your screen automatically. And we look forward to continuing this conversation, perhaps tomorrow at the Resident Forum. And once again, thank you so much, Craig, for joining us today, and for everyone who tuned in. Have a great afternoon.
Thank you, Craig.
Thank you. Thank you for the opportunity. Have a good day.
Thanks.
You too.
Bye, Anne. Thank you.